of awareness about ERNs at national level was still low at that time, and the health authorities and the Ministry of Health did not understand the importance of being part of ERNs for our healthcare providers. We invited patients, but also experts, and we organized the meetings in 2 days, one for experts and one for patient advocates. And we organized everything at the Neuro Center and invited Ministry of Health to attend our meeting. And suddenly and unexpected, very unexpected, the Ministry of Health accepted and she came to our meeting. So we organized this in 2 days, as I said, and we had in total 65 participants. We had 5 coordinators of centers of expertise that were already full members in the ERNs, and we had at the meeting 5 new experts that declare that they want to apply and prepare the documentation for accreditation of their center and apply it in the next call of the ERNs. That was the result of the meeting. The first main result. What we achieved in this workshop was that we had more people informed about the organization of care at international level, more experts from the centers willing to participate in the European reference networks. We updated information, we had updated information about ERNs future calls and the call for associate members and how to organize a national coordination hub. And of course, we gained more interest from the Ministry of Health to improve the access of centers of expertise in Romania, and we've got the promise from the Ministry of Health that they will continue the accreditation of centers of expertise, which was stopped for almost 1 year. Since then, we accredited 10 more centers, and now at that time we had 11 centers of expertise. Now we have in fact 14 which have already the accreditation certificate, and 7 that are waiting for the certificate, but they were approved. And what we also gained was more interest from the patient side, the patient advocate side, and we had a first list of patients that were determined to organize themselves and to participate in trainings using the ePAG model to organize trainings for so-called roPAG, so patient advocates at Romanian level. And we decided together how to organize ourselves and do training for them in order to be better prepared to work around the centers of expertise in Romania and to, in future, cooperation with the ERNs. So why to organize this training? Because we wanted to increase the role of patients in organization of care system at national level. We also wanted to stimulate a recognition of expertise, because it's not enough that the Ministry of Health accreditate the centers of expertise and allow them to participate in ERN. We want that the Ministry of Health to be convinced that this expertise have to be somehow paid and paid differently from the normal healthcare providers, and to increase the funding allocation to these services. We wanted also to improve the cooperation and collaboration between patients and experts in designing services according to the needs of patients. Because
sorry, Dorica. I think Sophie, you are typing and it's audible and it's a bit disturbing. Could you mute your microphone, Sophie? Pierre. Thank you.
Okay. So we really wanted to find a way to bring together patients and experts and improve the cooperation between them, and to be able to bridge the gaps between the health, social, and educational services in Romania, And of course, we need these trainings because we all need to learn how to work together mainly. Because we say patients that we are the main experts, and experts say that they are the most important, but we have to come together and find out which are the needs of patients, which are the needs of experts, and find ways to work together. We designed our training in 4 modules, 4 main modules. So one was for knowledge generation, the other one for effective partnerships. Then we had a module on communication, and we will have a module on leadership. For the moment, this is not developed. How we organize the trainings, we organize workshops and working groups to develop communication, planning, problem solving, and negotiating skills for the patients. These are the 4 modules. And for instance, for knowledge generation, we organize capacity building workshops to collect their personal experience, the patient personal experience, and develop guidelines for integrated care based on disease and group of diseases. And for the moment, we have already 6 different guidelines, integrated care guidelines. For the module on effective partnerships, we train patients to build effective relations with and partnership with centers of expertise, and involve them in writing, assessing, and using the guidelines. Also we train them how to see the needs root and the problems and how to solve their problems. For the communication module, we develop a communication module with mass media and with journalists, and we also involve them in the training for journalists. For leadership, we want to dedicate this module on how to develop their personal leadership style and how to become leadership facilitators. These are the main modules, and what we achieved until now to clarify the role of roPAG in a centers of expertise. To develop a common understanding and vision for care development together with the professionals, how to improve the services dedicated to patients, especially the integrated care, and we also have a part on GDPR and data protection. We organize group meetings, and we had one meeting with National Council for Rare Disease, also with patients. For building collaboration and effective partnerships, we organized teamwork and partnership. We had teamwork and partnership as a team, shared personal experiences, and the co-creation guidelines for integrated care for 6 diseases. In cooperation with the centers of expertise, and now the centers of expertise are recognizing the guideline as useful, and we will propose it to the National Council for Rare Disease, and it will be on the website of the Ministry of Health. This is what we would like to achieve with these guidelines. As a result, we started to create a culture of patients' involvement in training activities and become roPAGs. We organize trainings, meetings on congenital anomalies, metabolic disease, and rare rheumatological diseases. This is what we achieved until now. And we produce 6 guidelines for integrated care for patients with Prader-Willi syndrome, Williams, Pompe, Gaucher, Hunter, and Fabry. And involved trained patients in Rare Disease School for Journalists and in a Hack Rare. It is a hackathon that we organized during the Rare Disease Day campaign, and patients have worked together with healthcare providers, and also IT people, but they worked as teams to develop IT tools for their needs. We initiated 1 week ago the informal school for rare diseases to sustain our activities from a project that we are developing together with professionals from one of our centers for congenital anomalies with intellectual disabilities and in-of-care project. This is how we consider that networking and cooperation between patients and professionals is very important. And this is how, in fact, our center is involved in different networks, both at national level and international level. So we are part of this network, RON-MCA-ID, which is part of ITHACA. Then we are we have case managers, and we created community nurses and responsibility groups in community. We are part of a resource network together with other specialized social services resource centers, and of course we are part of EURORDIS, and we are cooperating with Ministry of Health, Ministry of Work, and so on. Regarding the main factors that we consider were very important to achieve our results were the interest of participants at the workshop was higher because of the EURORDIS participation. We consider that without it, probably in July, we wouldn't have so many experts or patients. We have a good cooperation with professionals. We have, for instance, the Romanian Genetic Society as part of Romanian National Alliance for Rare Diseases, and we have historically a very good cooperation with professionals in Romania, and we develop good cooperation with other professional organizations. I think it was very important also for our to achieve our goal, the presence of the Ministry of Health at the workshop, as both in terms of promotion and sustainability for our work and for our proposals. But we think that it was important she was there, but after that we had to follow this workshop with several meetings with the Ministry of Health. We organized the workshops with patients. We had 2 workshops with patients and patient organization meetings, events, and with patients and experts. And in order to organize all these activities, of course, we needed resources. So we need to integrate all our goals into the projects that we had, and to look for new projects to be able to allocate time, money, and human resources for our goals.
Okay, thank you, Dorica. That was quick, brilliant. Any questions? I'm going to stop sharing the screen. Is there anybody that has questions for Dorica? Anyone? No questions?
No.
Then I'll do one. I have one question. And I think it's also part of, has to do with this, what you were explaining, Dorica. Hold on. So I'm going to share again a screen here. This that you have described here, this is very interesting. So you've been able to do all of this. Basically, what you've done is to mobilize patients at national level to get involved in, you know, to get involved with clinicians and to start working with clinicians, right? As you were doing it in the ePAG. Now, do you also and you've explained that part of the training is to convey what is their mission and the vision of their role, and I was wondering if their role at national level, are they going to have any? How are you going to link back what they're doing at national level with what you're doing at European level? with the ERNs, you see? How are you going to make that bridge?
So, of course, the most important thing is to have patients which are very active in centers of expertise and share their vision when it comes to organizing care for their needs. But also, we want to involve this group of patients in activities at European level. For the moment, we don't have so many ePAGs from Romania. We only have 2, and I think just 1 is active, except me. And we would like to have more, but to organize them together with their center of expertise that will attend the ERN. So to pair them together with the center of expertise and through them to be active at European level, to have a more active role. And what we also would like to achieve is because for the new call, probably we will have new centers, affiliating members, or some of them will go for full membership. But we probably will not have members in all the ERNs. So we would like to have a pool of patients that are prepared in order to be able to organize a national coordination hub and to be recognized by Ministry of Health and to transfer the expertise from European level into the national level. And we want them to be prepared to convince the centers of expertise when we have more centers of expertise than one in one cluster of diseases, to convince the leaders of these centers to organize themselves as networks at national level. Because only this way we will have a structure that will be effective at national level and will be able to connect with the European level.
I think that what you're trying to do is massive, and it's super, and it's very good. One of the success factors also here, and it's very obvious because you might not realize, but is that you are part of the National Alliance, right? And also an ePAG.
Yeah.
You wear the 2 hats.
I'm in contact with all the patients from different rare diseases, yes.
And you understand, you do have a whole kind of understanding of what's happening at national level and at European level, and that's very powerful, I think, to have this kind of interaction and to organize this kind of network. I'm going to stop sharing now. So thank you, Dorica. Really, I really like this, and I think it's really powerful. I would like to see this happening.
Yeah, me too.
Especially in other Eastern European countries, is very much needed, I think. Listen, Ami and Sue sent me. Hold on a minute. Last version of the thing, and I'm going to pull it here. Is this one? No. Is this one?
I have a question.
Yeah, go ahead, please.
I would like to know, how did you manage to get a Minister of Health to your meeting? I can't imagine a German Minister of Health to come to a meeting like this.
May I say onto that we, Ruth, we had invited SPAN to the year Rare Disease Symposium in Berlin, and it was the very first time in 12 years that the minister didn't show up.
Okay. Interesting.
Okay, sorry, but here it is. Ami, okay. Okay, here they are. I don't know why I didn't have them. The ministry in Spain, also the Ministry of Health hosted a meeting, an ePAG meeting, not so long ago with the National Alliance. Okay, so I'm going now is Ami and Sue to present. They will be presenting and developing patient journeys. So this is an exercise that they did this year. Also quite interesting, I think.
One question. If I understood it right, Danica is from an national alliance, or are they yet?
Yes,
okay,
Dorica is, yeah.
Because I cannot imagine one organization organizing the whole thing. So
one organization.
Yes, yeah, one alone, and a small one, not the national one.
No, yes, of course. You need to have the national alliance or that kind of support to do this. Yes, yeah. In the training also, huh? The training program is also very good, Dorica, and I think it's also very, very much needed. Yeah.
And now we will initiate, as I said, the informal school for rare disease, which will involve all different stakeholders, using the experience we have for 8 years with in working with the journalists, the Rare Disease School for Journalists. So we will do more schools for different stakeholders in order to train them on rare disease needs.
Okay, so Ami or Sue, who's starting? On whose turn is it? How do you want to organize this?
Yeah, can you hear me?
Yes.
Yes, I'm in big trouble here because I can't see my notes. So I will have to try to do this from my head, and sometimes it doesn't work. So we the ePAG group for ITHACA made a patient journey maps to see if everyone, all of us could see what the groups or the, no, I'm sorry. Sue, could you take over? Do you have the notes?
So should I just, is it okay if I just read it then?
Yeah, just read it.
Go ahead.
I realized that I can't talk. Thank you.
Right, well, first of all, there was a summary. Oh, well, maybe I should start to say that the duration was about 3 months, but it's still ongoing, and that, you know, hopefully other people will do some patient journeys. It was me, Ami, and Matt Johnson doing it with us and helping us a great deal. And also the other ePAG representatives did. Yes, there's a slide. There's Gabor, Yvonne, and me in the middle, and Annalise, and then Ami there, and Matt's at the back. And Dorica, who's just been speaking, is hiding behind there. But we're very fortunate we have Dorica in our ePAG, ITHACA. The summary was that the ePAG patient advocates developed a disease-specific patient journeys from the perspective of patients and parents, mainly parents, because most of our children have quite severe learning difficulties, as a reference point for the ERN pathways, guidelines and information sharing. Patient journeys are personal testimonies from people with first-hand experience of living with rare syndromes. They map the natural history and needs of patients along their life journey through the patient's or parent's eyes. The needs of patients are multi-system in nature and require a multidisciplinary team to support the patient based on the needs identified in their journeys. The approach was developed in the ERN genitouris, but is relevant to other rare diseases and networks. ERN ITHACA covers a wide range of rare diseases and syndromes, and patient advocates were unsure about representing other rare diseases other than their own. They were given the table to map specific needs and obstacles for the rare disease they present, along with the different stages of the pathway, depending on their experiences and the experiences of others living with the disease. The information presented in the table, so it was the tables that you saw before. No, sorry, another table. Sorry, I've lost where I am now.
This table, right? That you prepared,
yes,
that Matt prepared for you.
Sorry, I'm kind of looking.
That's okay. That's okay.
They were given the table to map the specific needs and obstacles for the rare diseases they represent along the different stages of the pathway. Oh, yes, I said that. Okay. The information presented in the table was summarized into a visual patient journey or route map to support the user-friendly communication. And they're those. We've got more put together there. At a face-to-face workshop with the ERN coordinating team, each ePAG patient advocate presented their patient journey, their life journey from first symptom, diagnosis through to care, treatment and follow-up. This was presented to the wider ePAG group to support better understanding of each other's diagnoses. Between the presentation, the group were asked to highlight common needs that others had also experienced in their rare disease. The common needs for all the ERN ITHACA syndromes were captured through this workshop and summarized into our one common patient journey. The next step is to identify recommendations for each of the common needs identified and for the ERN to address both at a strategic and operational level how the network will address these common needs. Sorry, that was a summary. So I'm not quite sure, because I wasn't doing that, as to which, I hadn't worked out which slide went to which particular bit. So that's a summary. Then there's the initial situation.
You can go to the success factors, because the initial situation you already kind of went through.
Okay. So you so just go to straight to success factors then. Okay. Yeah. So there was also initial situation and the contribution of the patient. But right. So success factors. We were provided a common template in which we were asked to describe our experiences and desires by answering specific questions. That made it easier to compare the different disorders with each other. It provided us with a structured way to share our experience and expertise in a common approach. Doing the mapping exercise in our own home environment at our own pace and not as a group exercise made it easier to really reflect on the reality of the healthcare services that we could access and what was the gap with our real needs. It's so easy to lose your thread when you're having group discussions. Another thing was having a clear visual for each disease pathway made easier the comparison to identify the common situation and needs. The journey made it easier for us to engage with clinicians. At a face-to-face meeting with ITHACA, ePAG patient advocates, and the ERN coordinator, Alan Veloz, we all presented our own syndromes pathway in a more relaxed environment, and we could all share our own experience. After every session, there was enough time for reflection and questions. And I certainly found that really, really rewarding, hearing things about, though you read about different syndromes, it was just so much better the way it was presented to us. The common needs of all ITHACA syndromes were described in a document, and they are now being used to advocate for the needs of all patients represented and to inform the development of the ERNs and inform the development of the ERN scope and structure. But having someone facilitating, collecting information is crucial to this exercise. Then the next slide would be the lessons learned. There was a need of a facilitator to lead the work, and this was Matt. The ePAG patient advocates need to be committed to the exercise and work together, which I think we were. We learned more about each other's syndromes and found out that even as the diagnoses are different, we do have similar needs. That's quite striking, actually. The exercise brought us more united in the group. Sharing brought us more together. We found out that the healthcare services for the same syndrome varies between countries. We learnt about the importance of getting other parents' input to complete this, to be sure everything was captured. This is particularly important if there is not a complete natural history for a syndrome. We learnt how similar some of our issues were. It was made clear that psychological support was very much needed for parents getting a new diagnosis. And we learnt that patient groups might need external help to describe their journey and fill in the templates, particularly particularly those where the children have developmental delay and need a lot of input from therapists. And that's it.
Ami, do you want to add something now?
I think you covered all of it. Just for questions if you have any.
Okay. So the floor is open for questions now. No questions? Has anybody done anything similar in their own group?
Yes, we did at God Heart, but I'm not sure if they are available already. Do you know, Lenya?
If I remember right, there were 2 of you, right? Who filled out the template, and then the rest of the group decided it wasn't for the whole group, right?
Okay.
So one question that I have for Dorica and Sue and Ami, because they were all 3 involved in this exercise, was when did they decided that it was worth for them to put the effort into this? Because it took a lot of time, as far as I know, right, and some effort on your side. So what made you think, okay, yes, this is worth doing?
Well, I think it was because Matt suggested it, and we wanted to get our teeth into something. I think it was daunting at first, but it was a very enjoyable and very worthwhile project to do.
Well, I could say that the what we did, that was Matt's idea, but from the beginning the group had a problem to represent other groups, and they didn't know, we didn't know what kind of experience you have when you have another disease. So
how many were you? How many were you doing the exercise? I think you mentioned, but
that was a 5 or 6.
5 or 6. Okay, yeah.
We did this exercise also at national level some time ago, and we have a brochure on patient journey in Romanian, but it was done as an exercise to see how it was in reality, this pathway, and how it should be in ideal world, the pathway. This was our first goal to do it, and that's why when the exercise from Matt came as a proposal, it was great to do it. And for Prader-Willi, for instance, there is a research project. They are collecting at global level 500 patient journeys for Prader-Willi. They want to collect 500. And I'm curious what will be the result, because I think even in the same rare disease, the pathway is very different. So
depending on the member state, on the country.
Yes, I'm very curious about the result.
So Christian,
it's a great exercise to see where how it was for yourself and how it is now and how should be in the ideal world.
And as far as I understand, you are using the results also to advocate within the ERN and to engage with the clinicians on next steps, right? On
yes,
what to do next.
In order to create services, to adapt services.
To adapt.
Yeah. And also it's very useful for the case management. Because if you do this exercise with the patient journey, it's a very useful tool when you work as a case manager in order to define the services that a case need and a patient need, and how to put in contact to faster the pathway and the access to different services and bridge the gaps between different services.
So I think Christian Grun has mentioned that they're going to do it, or they're doing it now. And which ERN is this, Christian? We can't hear you. You can type it otherwise.
Maybe like this. You can hear me now?
Yeah, we can hear you now.
Hi, everyone. Hi, everybody. I'm in the board of the Patient Association in the Netherlands for bladder extrophy.
Mm-hmm.
We are working also on the patient journey right now. However, I found it quite difficult because the situation per patient is quite different. And I also feel that people also have personal choices, because some steps you can do some surgery, but it has a lot of complications and consequences. So it's not a one-way street, you could say.
No, that was a problem that we had when we were filling in the template. That you're not really. It's not the journey. You can't describe the real journey that you're doing, but you can have it in just not the specific things that you're doing, but what the common things that all of us are doing. You know, not everyone is not the same. So some of them has done a surgery and some hasn't. So you have to take some kind of a equal. Do you understand what I'm saying?
So the minimum denominator for everyone was kept.
Yeah.
It's not only
that's kind of finding a standard, and you decided between yourselves, you decided what was a standard, right?
Yeah.
But that's the problem. I think in the end, it's not a standard. I think in the end, it's you have several choices. So just to give a very concrete example, people can make a choice to close the bladder and to start using catheters to urinate. But it is very hard to reverse. So once you did this, you're depending on that, and you cannot also change back. But it really depends on the severity of the problems, if it's needed or not, and also the personal preferences, you could say. So I feel that it's the most ethical way to deal with this is to show that there are options, but not to say that this is the way or the standard.
But that works if you only have one disease to take care of. For example, I have spina bifida, and we also have a bladder problem. So in this patient journey, you can't say, oh, we are doing this kind of surgery to help the bladder, or we are taking medicine, or so. So we just say we have a bladder complex situation. So we're not going into what
the treatment.
The treatment for the disease. It's just what we are going through with the doctors.
Yeah, I'm going to show the one maybe from, again, just so that you see, again, the example, so that you see it's not, and I'm going to do this one, for instance, big, so that you can see the Prader-Williams one. But it's just not very good quality. Anyway, we will share this. But yes, as Ami was mentioning, there's just, what's going on here at the different stages, and what are kind of the ideal support that the patient will need at each stage. But of course, they didn't get into the details of what type of surveys they got, because that's very different, in the different countries, right? So there's no way that you can...
Yeah, and sorry to interrupt, but Elena is saying something in the chat. I think that is important. And maybe we need to differentiate the patient journey from the clinical journey. I think that was that point that Matt made as well.
Yes, so this is different, yeah.
And Ellen has raised a hand. I don't know, Ellen, I think you're not muted,
yeah,
so you can...
If I can, yeah. I'm driving actually, so it's difficult to raise hand and so on. But I wanted to say that in the ERN Reconnect, we have started to write patient journeys based on the presentation we had. We've also started to do it amongst the lupus patient experts. And what we find is that it's very useful also just to start to be able to better express your story, and then to compare and find both the common points and the differences. Because being able, when you are involved in research, to understand what are the different experiences than yours is extremely important. And so that's also a use that you have in the patient journeys. The one part which we are trying to add is the emotional journey, because that is very little covered in the patient journeys, which are more focused on the medical side. But we think that the emotional side is also something very important and might help patient organizations and multidisciplinary teams to better deal with the various stages that people go through. And I think it's an important fact to add. That's
very good, Alain. So just to clarify the difference between this exercise, patient journeys, and the clinical pathway. So what this allows you is then to map the patient journey with the actual clinical pathway that you have in your country and see where are the gaps. With the patient journey, you have identified, the different needs that you have. Then if you map it to your clinical pathway, the one that you have in your country, it will allow you to engage with clinicians and eventually with the health authorities to identify where are the gaps, where are your needs, and where are the gaps. So, it's kind of is a way of looking into the reality from two different angles and then mapping those together. Vasker and Elena, I think that VASCA has VASCA group in your ERN. They have done already something, but not quite this. I think that they did a slightly different exercise, right? The VASCA group.
I think so. Maybe Lisa can tell more about that. And she has a question. I meant our HDAD group. We are also putting, we are saying that the emotional and psychological part is really important. Mm-hmm. So that was what I was mentioning. But Lisa has a question and maybe can tell more about VASCA because she's in the co-chairs.
I think that what VASCA did, they call it patient journey, but it's actually the clinical pathway. I need to see it because they have again, there's a question of terminology here that we should be more, all of us, careful about. But I need to see it. They have already published it, so I wanted to have a look at that. Lisa, go ahead.
Yeah, please, because I need some help here with this, because we were going to make this pathway, and then we had just a 20-minute introduction by Matt. And what I found was that we didn't have enough time. Now when I see it, I find that it would be very useful if we could sit together as a group and spend maybe a couple of hours on it and do our individual pathways. And then we could see what's the same and what differs, etc. And then later on, we could have a long sort of discussion with the clinicians. So far, we have not had that opportunity time-wise, I would say, because I do think it's very good. But what we stumbled on was that it was also incredibly different in all our countries. So we found, right, we have to take another route, But it is a very good thing to sit and have as a basis for discussion, I think. How would you use it? How much time did it take you to do this? Did it take you, you were talking about 3 months?
Oh no, we did it over time. I mean, we didn't do it all at once. We did it in different sections. I certainly, when I was doing the patient journey for Pitt-Hopkins syndrome, my son doesn't have some of the more obvious symptoms. So I was definitely collecting symptoms from everybody, from the patient group, our parent group, and then I showed it back to them, and they said, "Oh, what about this or what about that?" which I hadn't thought of, and I added them. Mm-hmm. And then I showed it to Professor Hanneken, who I always go to for any questions about Pitt-Hopkins syndrome. Mm. And again, he made some comments about how some things should be expressed in a different way to be more useful. So but I think we all did it in different ways, depending, because we didn't really have anything like that, because Pitt-Hopkins syndrome has only really had a blood test for the last 11 years or so, or 12 years. And so we're very much creating these things as we go along. It's not like with, some of the other syndromes that are kind of like well established in themselves in patient parent groups to get these things written out over the years.
And I was wondering, do you find that, was it all over the lifespan, kind of? Or were your syndromes sort of diagnosis, childhood and a bit on? Or was it all over?
Well, as our the blood test only became available in 2007, I mean, my son was 16, and we just happened to be at the right place at the right time to be in a research project which then tested him. But a lot of the children are now being diagnosed really quite well, if they're fortunate enough to have something like access to whole exome sequencing, or some came through the DDD, or some doctors actually recognise Pitt-Hopkins syndrome because they've heard about it. They might be as young as 2 years old. So we've got a lot of very young children, and there aren't so many of us that have older children. The oldest that I've ever met would now be in his early 50s, and he's in the Netherlands, which is why I met him, because I lived in the Netherlands. There's a young girl in the state, I'm so young, she's 39, and I've heard from Professor Jill Clayton-Smith that she'd certainly seen some people in there a few years ago in their late 30s, so probably in their 40s. But most of the information really we have is from up to the age of 25, probably when my son's 27. But we've only got a few get the information from, which is why it's so important to raise awareness, find more people, then learn more about our children through the whole journey.
Exactly. Yeah, it was very useful to hear this, and I think we will all really benefit from looking at all the different ones. And then I suppose that we need to take another look and see where it could fit in, because we have a disease which is quite well documented, but not the mental issues and the psychosocial issues. So we are focusing on that.
I think what came over to us was how very few parents had any kind of support groups, really, and that came across from a lot of us.
So that was a very good point to raise, and it became obvious when you did the pathway. Okay, thank you.
Elena, yes?
As Lisa asked about age or diagnosis, this could also be two different approaches, isn't it? One more clinical, how the patient feels when you get the diagnosis, you learn about it, and once you are an expert about that. And the other one could be more life stages, like infancy, adolescency, teenager, finding a job, or should I go to the uni, not job, and life going on, building a family, kid or not kid. So these are all different approaches. And is it possible to put them all in one? I don't think so.
No.
No, we are not putting in the psychological aspects to everything. Is in that way it's a little bit clean. Just talking about the medical treatment, but we have one note saying that there is a need of psychological help, but nothing more like that. And you were talking about the timeline. There were only 4 steps: a pre-diagnosis and first symptoms.
What?
I don't hear you. Your mic is out. And Lisa, I think yours is on.
I have my dog in my lap, and she was she pressed the mute button. So there are a lot of notes in each template that we have. So, and a lot of things are written under follow-up care. And I would say that the lifespan is the whole life. Because at the follow-up care, then there you have it, all the things that you wanted to do and what's needed to do and how you want it to be and how it is.
Did that answer to your question, Elena? Not really.
It's just like she said, we stick to the clinical things. So then it's a clinical pathway from the side of the patient. Then for me, it's not a patient pathway then.
No, I don't think I don't think that we concentrated on clinical aspects. I think it was more an integrated approach, and at least in Prader-Willi, I referred more to different services, not only medical, but also the social needs and family needs and things like this, even to happiness, the need for happiness for the child, and as part of the treatment. And I think that it can be used in different ways, but it is a good base to start working on a guideline, care guideline, but not a clinical guideline, but care guideline. I think the pathway it's a very good exercise before starting to work on a clinical guideline, and it can be very useful also to observe the gaps in the system and to see where, from the personal point of view, how it was, how it is, and where are the differences and what should be done. I think that's why it's very useful exercise.
Yeah.
Okay, then I'm happy to see the ones which are ready, because I think until I see some samples, I don't get really the idea.
So just to close this discussion, because I'm unconscious of the time. The beauty of this, Elena, is that if you organize it in this way, so by stages, like a clinical pathway would be organized: pre-diagnosis, first symptoms, diagnosis, first treatment, surgery, follow-up care, and then you put in the information on clinical presentation of symptoms, the patient needs, what will be your ideal outcome in each of those phases. You will then be able to map that with the actual clinical pathway, because those stages are the same. It's the same. This is why I was saying is the same journey, but you look at it from different angles, and then you are able to map both things, and then you're able to see where the gaps are, because you have organized information in the same way, sort of to say. But you're not.
Then the difference more is like the same pathway, it just seen from the patient or seen from the clinicians? From
the health system perspective. Yeah. So how is the health system organized? What services is providing a diagnosis? What services are they providing for follow-up? What services are they providing? Okay. This is, and then you're able to engage in a discussion with doctors, because you're talking about the same thing. But you're bringing in a different perspective.
Okay, because for me the pathway of a patient is the whole life. This is why I wasn't sure if it's the stages in life or it is the stages of the diagnosis. So
follow up can be until
but it's really different if you realize it when you are 4, when you are a newborn, or if you are 16. So okay, thank you for the clarifying.
Okay. And Renee is also in the chat box. She's just clarifying that the outcome document that was created does include a section on psychological support. And when identifying patient needs, you can include the need for psychological support. So any other questions for the ladies? No? Okay, so big thanks to Ami, Sue, and Dorica today for sharing this. We will be having more on patient journeys in Bucharest for those of you who will attend Bucharest, and I think we'll be able to exchange more on how to do this and what this exercise can bring. And that's it for now. For the next call, we haven't yet selected the good practices, but and we haven't launched a call for good practices yet. But first, we have Bucharest, and we will meet there in May face-to-face, those of you who are coming. And we will have time to go through some good examples also. So thank you, everyone, and have a nice evening.
Thank you.
Ciao.
Thank
We will share this in our website.
To see you in Bucharest.
Yeah, see you too, Dorica. Bye.
Thank you. Bye.
Ciao. Ciao.
Bye.